Sure, I think we're okay.
Into the women's ward.
Okay, so we are doing paniculitis this morning, and Shane, you want to lead us off with this?
Sure. So, looks like we have some nodular infiltrates. It's chicken soup, so lobular paniculitis.
So chicken soup, meaning the circles are big ones and little ones, which would be lobular rather than septal.
Looks like some fibrin.
And it looks like some fibrin deposition. So if you have fibrin, and a lot of this has gone sort of beyond fibrin to hyalinized collagen, but it means kind of the same thing. So if you have nodular lymphoid infiltrates and fibrin in the sub-Q, lupus paniculitis, and anytime you say lupus paniculitis, you must also consider sub-Q lymphoma. And our current understanding is that the lupus paniculitis gives rise to the lymphoma. It's not just that it's a mimic, but those patients, they actually do have lupus, and they but a percentage of them will go on to lymphoma. So all of them have to be monitored for it. One of the things that's helpful in this particular case is if you look above, there's even a little bit of interface dermatitis. There's excessive space between the collagen bundles where the mucin is. They're nodular, perivascular lymphoid aggregates, and vertical columns of lymphs in the mid-dermis. So there's overlying changes of lupus as well as the sub-Q lupus paniculitis. Well done.
So this is I think it's a pretty good example for pancreatic pancreatitis. We have saponification.
So you have saponification of the lipocytes with these ghost lipocytes. So very good for pancreatic. So who gets pancreatic paniculitis? Pancreatitis or pancreatic carcinoma. So if the patient is fat female and 40 with gallstones, they can get it. If they are alcoholic or have hypertriglyceridemia, they can get it. Or, when you see this, you would like their belly to hurt a lot because it means it's benign. Because if the belly doesn't hurt a lot, it's probably bad. And then the other thing that the patients often complain of is ankle pain, and it's thought that this happens very regularly in the ankle fat pad.
Bench biopsy. Looks like fatness kind of crystallized. And there's sort of surrounding palisade granulum around it, so thinking like a subcutaneous fat necrosis of the newborn.
So you have radial rosettes of crystallized fat, crystallized lipid, and you have granuloma surrounding it, so subcu fat necrosis of the newborn. What can look just like it?
Scleroderma neonatorum and steroid-induced paniculitis.
So steroid-induced paniculitis is the one that probably looks most like it. Scleroderma, you rarely get granuloma, although that's probably just because the kids die before the granuloma has time to form. So, very good. Kids are prone to sub-Q fat necrosis because their fat is more saturated than adult fat. So it's kind of like you put olive oil in the fridge versus corn oil. Corn oil doesn't solidify in the fridge, olive oil does. So the kids are more like olive oil. It's a kid with a sore lump in the cheek is commonly popsicle paniculitis. The popsicle was sitting there in the cheek, and they get something that looks just like fat, sub-Q fat necrosis.
So this is is a dense lobular paniculitis. Looks like that vessel is kind of has some thickening around it as well, and some larger microcystic changes in the back.
So lobular paniculitis, some lymphoid infiltrate
So
in vessels.
I think it's erythema nodosum.
So erythema nodosum is absolutely in the differential. So what would you want to check for erythema nodosum?
You want to check for tuberculosis.
And what's the best way to screen for it?
I would think doing a quantiferon gold. but-
Quantiferon gold for two reasons. One is the sensitivity of the test, and the other is the risks of putting a PPD on a patient with this disorder. So the first patient with erythema nodosum that I had as early in practice was a guy who had spent years living in Thailand, drinking unpasteurized milk and the like. He didn't have a pulmonary focus, he had a gut focus of M. bovis. And when he had a routine PPD placed, he necrosed. He almost ended up with amputation. The necrosis was so extensive in his arm. That's the kind of reaction they can have because of their hypersensitivity. So that's the other reason to do a quant gold. So what else can give you a suppurative paniculitis like this, though?
Are you calling nodular vasculitis a different thing?
So nodular vasculitis that's different from EI, which basically looks like EI, but you don't have tuberculosis. So that's absolutely in the differential. Other thing, let's ask the fellows. Anytime you have neutrophils in a paniculitis, you're supposed to think of alpha-1 antitrypsin. So make sure any time that that you see newts, you screen for that because of the risk to their lungs, liver. That's an important one. And then you said something else.
Factitial.
So factitial paniculitis and infectious paniculitis. Newts can just be suppurative. It can be an acid-fast organism. The rapid growers in skin, abscessus and colony will give you this pattern of paniculitis as well. And the factitial is most commonly injection of either fecal matter or vaginal secretions. So you'll often grow pure group B strep or coliforms and then you'll have an anaerobic smell, but usually not grow the anaerobes unless you do anaerobic culture. So, okay. Very good discussion in differential. More things here.
At first I thought this was more of a septal, but it spilling over a little bit. But I mean, a lot of those look like different size lobules to me.
So the septum is a little bit thickened, and yet in the lobule, it's not just spillover. You clearly have necrosis of the lobule with great big circles and little circles. And what other change do you see in the...
We see the lipomembranous change.
So lipomembranous change, like frost on a window pane at the edges. So that's most characteristic of what?
Lipodermatosclerosis.
Lipodermatosclerosis. You can see it in a variety of chronic lobular paniculitis, to include lupus. But if it's your major finding, you just have lobular necrosis and lipomembranous change. It's certainly compatible with lipodermatosclerosis. And then that's a clinical diagnosis. But often there's associated stasis change above in the dermis. You don't see it real prominent in this one, but it's always good to look. So that's the skin. And that's the sub-Q. So do you see any infiltrate?
Yes.
Okay, so there's a bit.
Looks like there might be some newts. And a lot of lymphocytes, though. Maybe some plasma cells in there as well.
So newts, lymphs, plasma cells.
A little caseating process there, it looks like. And is that like a beanbag cell?
Not a beanbag cell, but a cell in mitosis. And there are quite a few of those.
So you'd be concerned about a lymphoma or leukemia.
So for lymphoma, then look at the periphery and see, are there lymphocytes rimming the edges of the lipocytes? And you look for atypia and nuclear molding in those lymphocytes. If it's just in the sub-Q, it's more likely to be what kind of sub-Q lymphoma?
Like gamma delta or
Just in the sub-Q is usually alpha beta,
okay.
and that's the one with the better prognosis. If it looks dirty and necrotic, and there's nuclear debris, and you have a dermal infiltrate, and you have an epidermotropic infiltrate, that's the one that's more likely gamma delta, and gamma delta is the much worse actor of the two.
Alright, looks like predominantly lobular paniculitis.
Like predominantly lobular, you have necrosis of the lobule with big circles and little circles. Anything else?
Looks like, trying to decide what this infiltrate looks like. Maybe more like lymphocytes.
There are lymphs. Not a whole lot of lymphs, but there are lymphs. There.
I mean, some of these look more nodular, like right there.
So if there are nodular lymphoid infiltrates around the vessel, you might want to check for
I mean, I would
so nodular lymphoid vasculitis with necrosis of the lobule. You have to consider the possibility
TB.
of tuberculosis.
Right.
And
So,
what do you have here?
it's a little lipomembranous change.
A little bit of lipomembranous change. So given that, then you'd want to consider the possibility of
I mean, with nodular infiltrate, I would think of lupus.
so lupus,
But otherwise,
and
lipodermatous
also
sclerosis.
lipodermatosclerosis. So it's not unreasonable to work through each of those possibilities, which you can probably do by clinical pathologic correlation and some simple testing like a quantiferon gold.
Seeing a whole lot of lymphocytes.
No. And yet this is sub-Q tissue. So this is
So
what
some kind of
used to be the
caseating
patient's
necrosis.
sub-Q. So there's definitely a lot of caseous necrosis here. So when you see tons of caseous necrosis, you have to think of infection, TB, erythema nodosum can give you that caseous necrosis. Let's see if we can get it to hold focus there. It's mainly lymphocytes, but I do see what looks like maybe some tiny little ant head fragments here. So we probably have, I don't know why that wants to drift out of focus. So some neutrophil fragments there too. So it's caseous and some neutrophil fragments. You talked about TB, erythema nodosum, probably good to check a quant gold. What else do you want to check when they're neutrophils?
Alpha-1 antitrypsin.
Alpha-1 antitrypsin, which is what this patient tested positive for. So, important diagnosis to make. You can get a lot of caseous necrosis in alpha-1 antitrypsin. There are cases reported that are just fat lobules kind of floating in red soup where it's all gone caseous and just a few neutrophils scattered. So, sometimes you have to work through each of your possibilities.
So I've got some superficial and deep, looks probably like lymphocytic infiltrate. It looks like a lobular picture, at least in areas.
And what's this very intensely staining stuff?
Like fibrin or hyalinization.
So if you've got nodular lymphoid infiltrates and fibrin,
Probably a lupus.
so lupus paniculitis, and what's the other thing that has to be in your differential?
Sub-Q paniculitis like lymphoma.
Sub-Q paniculitis like lymphoma, and you even have around some follicles some little vertical columns of lymphs suggesting overlying lupus as well. Very good. That's good.
Alright, so another little punch here. Looks predominantly lobular, kind of dirty.
Globular, dirty,
Looks like you have some leukocytoclasia too.
so lots of karyorectic debris.
And think about possibly infectious or alpha-1 antitrypsin for this one.
So infectious, alpha-1 antitrypsin, anything else? With a lobular paniculitis, necrosis, can have neutrophils,
It's just like Erythema.
erythema nodosum, and this patient tested positive for TB. So sometimes, you narrow it to 2 or 3, and then you do your tests, and the result, tends to be highly relevant, regardless of which one it turns out to be.
So it looks like I see some basophilic staining material down in the fat.
So what kind of, that chunky blue stuff, what's it
looks like
likely to be?
calcium.
Calcium, and it's in
Which
every little capillary,
Right. So like calciphylaxis.
like calciphylaxis, which is, we see it in the metabolic chapter, but it's also a paniculitis. Well done.
So predominantly lobular paniculitis. In this scan, it looks like it's predominantly lymphocytic. I think based on density of nuclei.
And
You have some involvement of the septa.
so are the septi normal, or are they pretty wide?
I think they're wide.
And
I don't see any epidermis to look at the dermal subcute junction. Can you move up a little bit, just like so I can see the whole cube?
we can.
So there's your epi. Not really much infiltrated the junction.
And when you look at your lipocytes, do you have great big ones and little ones, or are the lipocytes all similar in size?
They're similar in size, which basically tells you that there's not sort of the necrosis within the lobule like you'd see in a lot of the more truly lobular paniculitis. So this one, like I told him when I gave the lecture this morning, even when you have a septal paniculitis, a lot of times you have some spillover into the lobule and vice versa.
Correct.
So this one is more predominantly septal, a little bit of spillover into the lobules. And I want to go and look for like Mischner's.
So you'd look for Mischner's granulomas in the septum because you're thinking
Well, the prototype for septal would be EN.
Because you're thinking Erythema Nodosum, and that often has those little granulomas with clefts, so they can be a helpful clue. So we'll look for them. Not sure that I'm seeing them in this, but that's because it's an early
Looks like there's
EN.
some newts in there.
So early Erythema Nodosum is neutrophilic, which is why colchicine works like a charm for early Erythema Nodosum. And things like SSKI can also work. Later it becomes lymphoid. Even later after that it becomes granulomatous, and that's when you get the Miescher granulomas. So very good. So you have a pattern of widening of the septum, lymphoid infiltrate at the edges of the septum, some neutrophils, and your fat lobule largely intact, so most likely Erythema Nodosum. This one I'm going to walk you through just because it's kind of a mixed bag. Definitely have septum with granuloma. I don't particularly see a cleft in the granuloma, but it certainly could be Erythema Nodosum. Except you go over to this side, and I see purulence, calcification. So at this point, infection would probably go highest on my list. If that's involving the fat, you'd want to include Eosinophilic alpha-1 antitrypsin. This person turned out to have TB. So maybe not your prototypical Eosinophilic, because I don't see a lot of necrosis of the lobule, but hopefully you'd cast a broad enough net with your differential that you'd walk through each of those possibilities.
So it looks, I'd say most of those lymphocytes are about the same size. They're a little bit larger than normal though, but it looks predominantly septal. The septum is certainly thickened, and it looks to be mostly lymphocytic, but maybe there's some granulomas down there. So I'd favor Erythema Nodosum.
So favor EN because you have thickening of the septum, inflammation at the edge of the septum, and not a lot of evidence of necrosis of the lobule. And that's exactly where I would go with that as well.
Definitely lobular.
Definitely lobular, so this
Very-
one has big ones and little ones.
Very dense infiltrate that kind of spills over into the septa. Looks very histiocytic, but there's some karyophrexis in there.
Yeah, so they're histiocytes, they're neutrophils, there's karyophrexis. So what
I'm
all are you
kind
going
of
to
in
include?
I'm kind of in that whole neutrophilic lobular paniculitis realm.
So what kind of things do you have to work up and consider?
So alpha-1 antitrypsin, infectious.
So you probably want to get
Factitial.
tissue culture, consider factitial, alpha-1 antitrypsin. Don't forget erythema nodosum, as pretty much any time you have a lobular paniculitis, it's probably worth getting a quantiferon gold. And this particular person grew coliforms and anaerobes out of every last culture that was done. It was always foul smelling and is likely factitial. That was the upshot. Okay, not seeing a lot of surface skin, but I certainly see a lot of fat.
It's definitely lobular.
So lobular paniculitis and some hyalinization around the fat rings. So makes you think of what kind of possibilities?
I think that would be more like possibly lupus around the rings if they're...
Absolutely. So you'd have to think of subQ lymphoma, but fibrin rings that become hyaline, collagen rings around fat. You at least have to consider lupus, which is what this patient turned out to have.
So very sparse inflammation in the fat. There's a few nodules.
Yeah, so you have a few nodules and not a lot of inflammation in the fat. So I don't see necrosis of the subQ. I don't see necrosis of the lobule. I don't particularly see a lot of inflammation in the septum. Just this, nodular vascular inflammation that has a few newts but is mainly lymphoid. So where are you going to go with differential?
Erythema Nodosum, nodular vasculitis.
Exactly. I mean, this is pretty wide. It's probably just early in the process where you're not seeing necrosis of the lobule, but erythema induratum, nodular vasculitis would probably be top of your list. Looking at the septum, there is a little inflammation in the septum. I'd put EN in there as well. And basically, you're going to have to work through each of those possibilities. Probably not alpha-1 antitrypsin, probably not infectious, probably not factitial, but you've at least narrowed your differential some. Okay, so tell me about the surface first, Dave.
Looks like you have that like nodular angioplasia.
So nodular angioplasia, and what's kind of the brown stuff in there?
Probably hemosiderin.
So nodular angioplasia and hemosiderin suggests
some stasis derm.
So there's some stasis dermatitis, and underneath
some pretty impressive microcysts and lipomembranous change.
So put it all together.
It's like some lipodermatosclerosis.
Yeah, I mean, it doesn't get any easier than that for you because you have the overlying stasis change really prominent. You have really prominent cystic change in the fat from the lobular necrosis and the lipomembranous change. And you see nice big vessels there that have no inflammation whatsoever. So it's a pure ischemic fat necrosis. Which would go with lipodermatosclerosis.
So lobular with saponification. So I would think of pancreatic paniculitis.
So pancreatic paniculitis, lobular necrosis with saponification of the lobule, forming those amphiphilic ghosty cells.
So lobular paniculitis with some death on the other one there. Mostly histiocytes and lymphocytes.
Histiocytes and great big cleft within that granuloma. Huge cleft in that granuloma. So now it's confusing, right? Because you've got like a Mischur's granuloma, but I agree with you, there's definitely necrosis of the lobule.
Mm-hmm.
So, occasionally the biopsy is doing funny things. It doesn't want to behave and be clearly one thing or the other. I definitely see granulomas in the septum. There's Mischur's granuloma. Here's another one where there's a granuloma and it's starting to form that cleft within the granuloma.
Old Enodosum.
So, an older Enodosum is a reasonable thought. You probably need to, in this one, look at the patient, see does it look like Erythema Nodosum. it's probably reasonable to do a tissue culture, work up for some of the other possibilities. Quantiferon gold is easy to get. This one, here's another, really nice, pretty Mischur granuloma over there, and the upshot is this one was an Erythema Nodosum, just very, very chronic, and it's got a little necrosis of the lobule.
Sir, can you show this close a little bit? Please?
I'm sorry?
Do you mind showing this close a little closer?
Sure. So that's like the world's best Mischur granuloma right there, where you've got those angulated clefts sitting within the giant cell. So it's not, a perfect lens like a cholesterol cleft. They're usually a little stelly like that, the clefts in the Mischur's granuloma. Okay, how about this one? You got your overlying skin, which has...
it all looks like dense infiltrate.
And now we get down into the sub-Q.
Yep, and lots of neutrophils still.
Is it predominantly newts or predominantly something
EOs,
else?
sorry.
EOs,
Yeah.
just wall-to-wall eosinophils.
So if you're in your eosinophilic paniculitis.
So what things give you eosinophilic paniculitis?
Arthropod, Schurg-Strauss, and
So arthropod, Schurg-Strauss, parasite, especially things like gnathostoma, that you ate sushi and now the worm is migrating through your sub-Q. And then the other thing is hypereosinophilic syndrome can do it. Schurg-Strauss is a vasculitic syndrome with eosinophils. Hypereosinophilic syndrome is eosinophils behaving badly and killing you in the absence of vasculitis. And this one, let's see what the history was. Myiasis. So changes adjacent to the maggot of myiasis. So parasite, you are correct. So, have some overlying dermal change.
Looks like predominantly septal. With some spillover into the lobule.
Yeah, predominantly septal, some spillover into the lobule, so that would put you probably in what kind of spectrum?
Like Erythema Nodosum.
Probably an EN type of spectrum. And then above, got a little xanthomatous change in chronic granuloma. So, that may just be secondary. Definitely an EN type of reaction, and this is in someone with metastatic carcinoma and kind of a reactive granulomatous changes in skin and secondary paniculitis. Let's see.
Looks like a lobular paniculitis. Granulomas around the periphery. Crystallization of the fat.
So what do you think?
So that'd be subcutaneous fat necrosis of the newborn or steroid.
So fat necrosis or steroid necrosis, because you see the clefts. I think we have covered things pretty well. In the remaining time that we have, let's do some potpourri. I'm going to grab a potpourri box. Any questions about any of the paniculitis entities before we move on to potpourri.
We have newts and like early eating newts in the septum. You still have to consider infections. You still get blood stains.
That is absolutely true. So the point that you made was that early Erythema Nodosum is neutrophils in the septum. Do you have to consider infection and do bug stains? The answer is absolutely, and especially acid fast in that setting. Okay, let's go ahead. So, where'd we leave off?
Me. I think I've got some like bacillar elastosis, like kind of muciny looking stuff.
Yeah, so muciny looking stuff in the dermis, anastomosing pink strands, blue buds at the tip. So tumor, solar elastotic skin.
I'm trying to think of the name.
Yeah, anyone want to jump in?
Pincus.
Pincus.
That's it. Yeah.
So the
Pink strands, blue
fibroepithelioma,
balls.
exactly, pink strands, blue buds, and the fibromyxoid stroma. Very good. Pick our best ones here. Okay, so first off, the way it was gross, this can only be one thing.
It's a worm.
Nature's worm.
Takayasu.
So Takayasu would be artery or great vessel. What would be vessel about this size with giant cells in an artery?
Like a Wegner's or the Anka's. Bigger.
Any other kind of giant cell arteritis that you know of?
Temporal arteritis.
Yeah, temporal arteritis, giant cell arteritis. And so when you look at that, just at that gross, a vessel that size cut up into lots of little pieces, that's a temporal artery biopsy. And then you're looking for granulomas in the wall. If there is if there's no giant cell, there is no giant cell arteritis.
Let's see, it looks like we have some pigment maybe in the dermis. And like a cellular infiltrate, maybe like a blue nevus.
So you're thinking like a blue nevus possibly, and you definitely have dendrites filled with melanin. It's not refractile, so it's melanin, not hemosiderin. And then you have these other very bland cells with nuclear pseudoinclusions. So you have bland melanocytes, you have dendritic melanocytes.
So it's like a compound.
Yeah, or you mean combined?
Combined.
Yeah, combined nevus. Combined nevus, banal and blue.
Would you be wrong if you call that other one a common combined nevus of Reed? Some of the cells that look kind of DPN-like.
If they looked a little DPN-ish, absolutely. Yeah. Any kind of benign nevus would be fine, in terms of patient outcome.
You have some interface there centrally within the field.
Sorry, let's get focused there. Okay, so a little bit of interface change.
Based on the biopsy, it looks like mostly, we don't have data to evaluate, but there's superficial perivascular and lymphocytic acidic infiltrate with interface change. There's a little bit of compact hyperkeratosis with some foci of para. I'm not seeing any extravasated red cells.
Agree.
And the lymphocytes. I'm not seeing much in the epi.
No, so
I think I have to give a differential, and you could consider acute LE.
absolutely.
Dermatomyositis, graft versus host.
I think that that's very good, giving a broad interface differential. Is your corneum normal or abnormal?
It's compact, kind of orthohyperkeratosis with some foci of para.
Let's look closer at the foci of para. Is it para?
Dermatophyte.
Dermatophyte. So, there is some actual para there too.
That's what I saw. Yeah, but lob.
And then hiding in with the para, almost mimicking other nuclei, are the little hyphae as well. So, tinea is one of those great mimickers. With this one, I think your approach to the slide was entirely reasonable.
I'm surprised there's not sponge.
Not a whole lot.
Maybe they were putting steroid in there too.
It could be.
Well, something neoplastic.
I would tend to agree.
Narrow that down. It seems to be like there's some peromostroma in some areas.
There is definitely peromostroma. You have that osteoid-like perivascular stroma.
But it's kind of dense and almost blue, and maybe some areas of necrosis. So I don't want to look and make sure it's not turning bad.
So your point is you see peromostroma, but there are a lot of blue nuclei and not a lot of pink cytoplasm in many of the areas. So porocarcinoma is probably where this is headed. I agree.
So we have a dense, almost band-like lymphocytic infiltrate and some specular change at the interface. And those look like Potre microabscesses and a lot of exocytosis maybe.
So you have a lot of epidermotropism. The lymphs, compare your lymphs in the epidermis to the lymphs down below.
They look a little bigger.
A little bigger, a little darker. And tell me about your papillodermis.
There's definitely papillodermal fibrosis.
Definitely papillodermal fibrosis. Your dermis is a very busy dermis pattern.
Mm-hmm.
So what things are in your differential?
MF, I'd rule out syphilis.
MF and syphilis are probably your most important two. And syphilis absolutely can be pseudolymphomatous and mimic MF, that busy dermis. You should screen for syphilis. This one turned out to be MF, but absolutely those are the two top things on your list. Well done.
I was just going to say, wouldn't LYP also, but MF?
The LYP type B that looks very MF-like, that is absolutely correct.
So, you have like a phased 3D.
So you have a phase 3D,
Some pigment there.
some pigment, and probably with the pigment some melanocytes. Are there good nests?
No. It's like a Glenigo maligna.
So like Glenigo maligna, is the underlying dermis normal?
No.
In fact, do you see any solar elastosis?
Not really.
Or do you see horizontally oriented, like a scar? So what is this?
Feels like a
Recurrent nevus. Well done. That's absolutely correct.
Big chunk of skin, not much of skin on the superficial aspect. And the subcube, there's some thickening. I'm not sure if it's the fascia or
Yeah, certainly, your whole connective tissue area is thickened. And you have these big spaces. Are they empty or are they filled with something?
there's something there.
Is it blood or what is it? And that looks like a vessel, but it's not filled with blood. What's it filled with?
It's like a foreign body.
or just lymph.
Oh, okay.
So if that's all lymph-filled spaces, and some are thick and more muscular, and some are very thin and delicate.
Like a lymphangioma?
Yeah,
So deep.
like a deep cavernous lymphangioma, cystic hygroma kind of lesion.
Sure. Sort of a dense lymphocytic and not trying to infiltrate down deep. There's the artifactual like cyst there.
So I
there's a lot of
agree,
newts.
that's probably artifact. Lots of newts.
Lots of newts.
And surrounding the newts,
Histocytes. So give like a palisade, maybe stellate granuloma.
like a stellate abscess within a palisading granuloma. What's your differential?
So collapse. Get this is LGV, atypical mycobacterium, tularemia, spore trichoid, and the C is
Cat scratch.
cat scratch.
And then don't forget on the vasculitic side that angiitis with granulomatosis, Wegener's could give you a similar pattern. This one turned out to be sporo. Well done. That's exactly the right approach.
It's a great paraterriform architecture. There's classy cytoplasm, and I like keratin. I'd call it a KA.
Keratoacanthoma, crateriform, glassy, hypergranulosis, centrally where squames just tend to get it at the edge. So very good for crateriform keratoacanthoma.
Yeah, maybe more like a wart.
More like a wart. So we're on acral skin, and you have tiers of perikeratosis, and you look to see, are they round? They tend to be kind of round. And there's papillomatosis. They kind of curve inward a little bit. So wart favored over early keratoacanthoma.
You have a dense infiltrate, a little bit of a crimson there, a lot of pigment.
Dense infiltrate, Grant zone, lots of pigment, excellent. And then what do you think the pigment is? Take a look up on the screen. See the way the pigment lights up?
Yeah, I think it's pretty refractile.
So, I'm sorry, did you say?
Refractile?
Refractile.
Yeah.
So which suggests that it's...
Melanin? Not melanin, sorry.
You are correct. It suggests that it is not melanin. It suggests that it is hemosiderin. And in here we see a wreath giant cell that contains hemosiderin, and there's another one just like it over here. So wreath-like siderophages are pretty much pathognomonic for dermatofibroma. Very good.
Yeah.
So hemosiderotic dermatofibroma, often very cellular. You could go down a SLAM differential, all kinds of scary things. But if you recognize that that's all refractile hemosiderin, and you recognize that there are wreath-like ringed siderophages, then you get pretty quickly to dermatofibroma. And you don't scare yourself or the patient unnecessarily.
So, it's like we have kind of a cystic cavity in the dermis. With lots of
Looks like atypia, right?
Yep, agree. Lots of atypia. And then, are these cells holding together or B, not holding together?
Acantholytic, yeah, definitely.
Acantholytic.
Like an acantholytic squame.
Well done. Acantholytic squamous cell carcinoma. That's exactly right. And
Looks like a melanocytic lesion.
looks like a melanocytic lesion.
Let's see. Pretty well nested.
Yeah, pretty well nested. So it looks like,
Intradermal or compound nevus.
yeah. And now, how about over there? Think about the junction there.
Looks a little atypical.
It's a little atypical. They're no longer as well nested. You have nests with odd shapes. They're not at the tips and sides of reedy. They're up in the arches. Very bizarre shaped nests. Cytologic atypia.
Like a melanoma.
And those atypical cells continue into the dermis. So melanoma are rising in.
And nevus.
Yeah. So nevus gone bad. Well done.
So I've got some sort of deep pigment in the dermis.
So something that appears deep and penetrating.
Like a DPN.
And so your first question is, does it only have normal collagen, or does it have its own sclerotic ropey collagen?
Its own sclerotic.
And is that a good thing or a bad thing?
A good thing.
That's a good thing.
Yeah.
That's what blues and DPNs are supposed to have. If it had, if it lacked that, then you'd worry about equine type, animal type melanoma. But it's got its own sclerotic, so it's probably a DPN blue type of nevus. And I think that's it. We're out of time. Well done.
That was easy.